Okay then, so thanks very much for those questions. So I'm going to talk about the main report, provide a summary of it, and I've got Karen, Simon and Anne to chip in if I forget anything really important. So as I said before, this is a project that is between University of Surrey, Brighton, Cardiff and also Greater Manchester Trust. We have a web page of the project where eventually the executive summary will feature. So if you want to find out information about the project up till now, you can access it still through that. Just to say that this is our interpretation of the report and not necessarily those of the Department of Health, just to cover ourselves. So there's quite a few abbreviations, so just to sort of clarify as we're going through, IP we use for independent prescriber, independent prescribing, SP for supplementary prescribing or prescriber, PPIP, that's our sort of acronym for the project, so physiotherapy, podiatry, independent prescribing, and NP are non-prescribers, PT are physios, POs are podiatrists, and MMA is medicines management activities. So if you can remember those, that would be great. It all becomes a bit wordy if you keep trying to say it as you go along. Maybe should have provided a crib sheet, but anyway. So just to give a little bit of an overview of non-medical prescribing in the UK. As you know, there's lots of different types of prescribers, which started off with community practitioners or district nurse health visitors. And there are around between 36 to 38,000 of those. These are nurses who can prescribe a very limited formulary, mainly appliances, dressings, P and GSL medicines, and 13 prescription-only medicines. Then we have the bulk of our prescribers, nurse-independent supplementary prescribers. This is any first-level registered nurse. And as of October last year, there was 36,000. And Sheila's already provided the information on podiatrists and physiotherapists. But as of October last year, there were 4,300 pharmacists, independent supplementary prescribers as well. So the numbers are going up. As Sheila's also explained, there's lots of different mechanisms to be able to administer and give medicines to patients. And so here is just like an outline of the times that are appropriate to physiotherapists and podiatrists. And I think that what this really shows is that the involvement in medicine sort of goes back quite a long time, and particularly for podiatrists back until the 1980s. So here is just a list of the aims of the study. Essentially, the aim was to evaluate the effectiveness and efficiency of independent prescribing by physios and podiatrists. I'll not read them all out because literally it'll probably take the whole presentation, but there's lots of different aspects. So the study was in 3 stages. Phase 1 was a literature review. Phase 2 involved a survey of people going through their training to become independent prescribers at the beginning and end of the course, an analysis of documentary evidence, and then phase 3, which was the major part of the study, was a comparative case study with economic analysis involving lots of different methods, including interviews, patient questionnaires, work sampling, observations of practice, analysis of consultations, audit of patient records, and of prescriptions that were issued. So the first part of the study, we undertook a literature review. And the overall finding was that there is just a lack of empirical work in this area in either profession. With respect to podiatry, the existing literature was very, very limited. It was largely descriptive, mainly written by Alan, who's sat in the audience, thank you very much, Alan, describing the legislative developments of medicines access and non-medical prescribing in the UK and Australia. But there wasn't really any sort of empirical research that you could draw on to sort of say what was happening in practice. Looking at physiotherapists, there was more evidence here, but the research was really sort of looking at medicines administration and the advice that physiotherapists were giving to patients about medicines. There was a common theme that there were concerns around the level of pharmacological training that people had in order to give this information to patients. And the key clinical areas for medicines management activities were in the areas of MSK, orthopedics and sports therapy. And it tended to focus around the use of simple analgesics and the sort of topical analgesics. So essentially our recommendation from that part of the study was that we needed to have a more robust evaluation. So even though there was a lack of empirical evidence, it was still interesting to see what was happening across the world. So then looking at the questionnaire that was given to people as they went through training, this was a longitudinal online questionnaire, as I said, that was given at the beginning and end of training. And due to the sort of timing of the project, we had to sort of approach people literally through the HEI non-medical prescribing course leads to sort of give people I forgot what the word is, a link to the survey and ask them to complete it if they wanted to. We also used conferences that we attended, professional newsletters through the CSP and the College of Podiatry, and through direct contacts that people made with us. Data collection was between March 2014 and April last year. So over the period of this 2 years, we sort of got in touch with the HEI leads every 3 months, hoping that they would sort of send reminders out. And we know from our responses at the end that we had responses from 26 HEIs across England. So it was fairly broad spread, covering all regions of the country, looking at it by Academic Health Science Network region, although 50% of respondents of the survey were based in the London area. The sample size for question 1 was 85 and for questionnaire 2 was 39. 48 people had been on the conversion course from SP to IP, so quite near the beginning of the process. 66% of were physios and 34% were podiatrists, and that was similar in both questionnaires. So at the end of the first questionnaire, people were asked to provide their contact details, and if they did, then we contacted them, and then at the point of when they indicated they'd be finishing the course, and that's how they sort of were invited into questionnaire 2. So looking at PPIP services and service provision, what we found from the survey was that 61% had specialist roles, 17% had general roles or worked in private practice, 12% were consultants or podiatric surgeons. Physios and podiatrists overall on Band 8A or higher, over 50% had a higher degree, master's or PhD. All had some sort of specialist training, and 68% had a master's level module. The key areas of service provision for physios and podiatrists were MSK at 36% and pain 11%. Other areas, profession specific, were high-risk feet and surgery for podiatrists and respiratory for physios. We asked people to sort of indicate what type of services they were providing. It was a very complex picture, I think is the easiest way to describe it. And basically, physios and podiatrists are working in lots of different ways. It's very difficult to sort of map out exactly what's happening. But overall, 58% were working in NHS, outpatients, and 20% in community clinics. And so we asked people to indicate the number of items they thought they would prescribe once they were qualified. So the blue bars are physios and the red are podiatrists. So as you can see, it's a little bit varied. Some are expecting to prescribe a lot, over 20 items a week, but the majority are somewhere between 1 and 10. We also asked people to indicate what areas of medicines or therapy areas they would be prescribing in. So on this graph, the orange is podiatrists and the blue are physiotherapists. So the key areas were for infections, either antibiotics, antifungal or antivirals, for musculoskeletal, for pain, gout, muscle relaxants, and then for anaesthesia, local and general anaesthetics, and for the central nervous system, such as analgesics, such as amitriptyline, antidepressants or hypnotics. They were the main areas. And then podiatrists were prescribing a lot for skin, but I guess that's probably to do with the fact that they're dealing with feet. Then within this survey, we asked about preparation and support for the role, which relates back to what we were talking about earlier about the designated medical practitioners. 80% said they felt completely or largely prepared to practice independent prescribing. Nearly 80% largely or fully met their learning objectives and personal learning needs. A few people, 6, reported some difficulty meeting the learning outcomes, and this was related to the volume of work required and in particular around numeracy. 75% reported that they had adequate DMP and employer support. So I think that we felt that that was all encouraging. Better than nurses at this stage. This is our comparison group, but trying to interpret sort of patterns of what's happening. So we asked people to report on what clinical governance systems were in place when they started to prescribe. And these areas were sort of established sort of quite a few years ago in previous work undertaken by Central London Strategic Health Authority. And what we found here was that most people had clinical governance systems in place. The main areas where there were gaps were sort of like there was differences between the professions. There were specific issues for physios around what's the place now?
Specimen signatures.
Oh, she's good. She's good. Specimen signatures.
Specimen signature. Yeah.
But essentially, I think when we had done this, when we used this sort of block of questions for nurses, there was very specific issues where some things were not in place at all around audit and I'm trying to think what else it was.
The main area is always around access to your own prescribing data and support to do audit, regularly auditing your own prescribing, which are areas that nurses and pharmacists have historically had issues with as well.
And I think one of the main differences between the physios and podiatrists and nurses was that everyone reported that they had access to CPD, which is quite a significant change, which is encouraging. So also looking at the facilitators and barriers to prescribing, what we found were that key motivators were being able to improve the quality of patient care, improving access to medicines and improving use of professional skills. Anticipated benefits focused around reducing delays, streamlining services, increasing choice, improved knowledge and job satisfaction. What we did find was that people who were like this early cohort of prescribers already had a very high involvement in medicines management activities, 84% reporting that they supplied or administered at least 8 items per week, and 94% making recommendations for medicines on a regular basis. Some of the difficulties that were reported were around securing DMP support and lack of governance systems around auditing and specimen signatures, which is what we just said. So, we also asked people in the survey to recommend contact within their organisation around workforce planning. We then sort of followed up on a large number of those, but we actually found very little evidence of any documents related to commissioning or service redesign at the point of when people were going through training. A number of people reported that changes had happened after they had the qualification, but not in advance. So it wasn't, say, for example, there wasn't any workforce around, oh, we want to have a prescriber because we want to develop this service. It was still more a case of people identifying that they wanted to go on the course and then seeing, oh, well, actually now I can develop a service around this qualification. And then moving on to the case sites, we had a total of 14 case sites across the country, some in the northeast and in the northwest. We followed 488 patients over 2 months. We had 3 podiatrists and 4 physiotherapists, independent prescribers, and we then compared these to 3 podiatrists and 4 physiotherapists, non-prescribers. As I said before, we used lots of different methods of data collections. So we had interviews with the podiatrists and physiotherapists, the wider team members. We had assessments of consultations, where up to 5 consultations per site was recorded. They were independently assessed by 2 people. Any prescriptions that were issued were also assessed for safety and accuracy. We audited up to 15 patient records per site, looking for information around service use in the 2 months following their initial consultation. We collected patient questionnaires after their consultation and then 2 months after that as well, looking at their satisfaction with services, satisfaction with information about their medicines and quality of life. And then we also spent up to 5 working days at each site sort of observing what was actually happening in practice. And Jude, our researcher, sort of recorded every 5 minutes what activity the people were doing. This was based on 23 different activities related to direct and indirect care. And so she observed 474 consultations. So there's quite a lot of data to draw on. So looking at the case sites in more detail, our podiatrists, we had people from private practice, diabetes, and consultant podiatric surgeons. Our physiotherapists were from different MSK services, orthopedics, we had consultant physiotherapists, extended scope physiotherapists, and clinical lead physiotherapists. They were all generally full-time, average age of 48, with a master's or a PhD and a band A average. Then sort of looking at some of the data in more detail, looking at the observations, the consultation rate across the 2 professions was approximately 90 minutes. One was a very short one of 2 minutes, and one was very long at 203 minutes. So I think that could be somebody who had a procedure, I think, that we found. Physiotherapy consultations were slightly longer than podiatrist one, and the prescriber consultations were again slightly longer than non-prescribers. Then looking at the type of patients that were actually seen within each clinics, obviously that's really influenced by the context of the service that's being provided. 66% were follow-up consultations, 33% were for initial routine consultations, and only 1 was for an emergency consultation. But I think that, again, that just reflects the nature of the patient groups. The majority of patients that were coming through to see the prescribers and non-prescribers were referred via GP services. 11% were seen in the private sector, and a small number, 48%, were self-referred. The observation diaries. This is where Jude, our researcher, sort of recorded what was actually happening during the consultation, sort of identifying whether the medicine was supplied, administered, prescribed, recommended, or adjusted. And we found that actually only 24% of consultations had any medicine management activity going on. More activity was recorded in the prescriber consultation, which is obviously great, that's what you expect. With respect to physiotherapists, most of the activities were around pain or movement control, including injection therapy. The independent prescribers for physiotherapists were more often observed to provide information to patients about how the medicines work and when to take it than those who weren't prescribers. Podiatrists were mainly involved in medicines to do with antibiotics, antifungals, antimicrobial topical creams, emollients and pain medication. And what we found in these consultations was that the medicines information provision was inconsistent, particularly if the medicine was administered directly during the consultation. So we're able to say a lot, but we don't necessarily know exactly why at this stage. So here it's just like a chart, just sort of breaking down the different types of medicines administration activities. So here the blue chart, the blue bar is the physiotherapy independent prescribers. Orange is the non-prescribing physios. Grey is the prescribing podiatrists, and yellow is the non-prescribing podiatrists. So you can see here that the non-prescribing physios are making a lot of recommendations to independent prescribers. And, sorry, the third one up, there's a lot of PGDing going on still with the prescribers in each group. And some other activities about making recommendations for over-the-counter medicines. So, looking at the work sampling, So as I said, there's 23 different types of activities related to direct care, indirect care, and related to services. And what we found here was that the podiatrists were more likely to be involved in indirect care, and the prescribers were more involved in care planning and computer use during the consultation, whereas non-prescribers were more active in providing treatment, room preparation and using computers outside of the consultation. A physiotherapist, the independent prescribers were more involved in medicines management activities and treatments, and the non-prescribers were more involved with discussing things with patients. Now, and then this is sort of a chart, you probably won't be able to see it very well. This is the 23 different activities, but you do need a bit of a microscope to be able to see it. But the main one is this direct care one here. That is therapeutic procedures. Anyway, so that's not such a good chart, but anyway. If you get the slides, you should be able to see it more detail. The patient questionnaire, we had a very good response rate to the patient questionnaire, which was given out at the end of the consultation. We had 315 questionnaires returned, 135 from physiotherapy patients and 180 from podiatry patients. Looking at the satisfaction with services and with the services and care received, patients that saw physiotherapy independent prescribers were, compared to non-prescribers, were more satisfied with the advice, were better able to understand their treatment, and reported that they felt treated as an individual. Podiatry independent prescribing patients reported it was easier to make an appointment. They're able to contact the podiatrist more by phone, and they were able to make emergency appointments compared to services provided by non-prescribers. Looking at the advice and information about medicines, 32% of patients said they received information about the medicines on the day of the consultation, and those in the prescribing group received it more frequently than those who saw people who weren't prescribers. Those who saw physiotherapists were more likely to be told when to take the medicine, how often to take the medicine, and found it easier to follow the instruction about the medicine. So that's all really good signs. 81% of these patients agreed that physios and podiatrists should be able to prescribe medicines. Sort of relates to what Bill was saying. At the 2 months follow-up point, we had a 74% response rate and just under 200 questionnaires. 20% medication prescribed or recommended. 20% reported that they'd had a medicine prescribed or recommended by the physio-podiatrist. 18 had received a prescription on the day that they reported would reduce waiting time. There was more medicines management activities reported by patients who'd seen prescribers, and this included prescribing via PGDs, exemptions, recommendations to GPs, or to buy over-the-counter medicines. We also looked at health-related quality of life using the EQ5D scale, which is very widely used. And for both groups of patients, the quality of life improved between baseline and 2 months follow-up. So I think that, again, it probably just reflects the fact that the type of patients seen by the professionals, and that you would expect them to be an improvement once you've had some sort of intervention. So it just goes to show that wasn't a very good use of a tool for this study, for what we were looking at. So looking at some of the interview findings with the professionals. So this is interviews with the physios and podiatrists themselves. A lot of what they said was very similar to what we found in our previous work with nurses. They reported benefits of service efficiency, convenience of access, choice, knowledge, quality of information. They felt it had a positive impact on their professional reputation and also on the scope for advanced roles. They also felt that their role had become more aligned with patient expectations of what a specialist was, and in particular it resolved legislative grey areas around medicine. Legislative grey areas. I can see Rosie cringing. Around medicine's management practice. Some of the barriers that were reported were around access to medical records because of the configuration of services, lack of patient follow-up, not being able to review the patients because of the way the services were configured, time, budget, training costs, DMPs, isolation, and also resistance to the role. Some of the concerns that were reported related to becoming a more medicalised role, with increased responsibility and cost savings. Another barrier that we found, as already reported, was that there was a lack of strategic planning at the point of implementation of the role, but there were plans in the future. And what we know from our previous research is, if there is more planning, some of these barriers that have been reported can be sort of alleviated or reduced to therefore support more successful implementation. But what we did find across both professions was that existing methods of medicines management, such as PGDs and exemptions, are still more convenient for the majority of patients, and the prescribing rate overall, even though there's a lot of activity, is actually technically low, if we're classing prescribing as the production of a prescription at the end of a consultation. So we're nearly there. So the audio consultations, as I said, these were each assessed by 2 people independently. And what we found was that there was actually quite a high level of disagreement between the assessors, well, very high level, actually. And there was more areas of concern identified in the non-prescribing consultation. With respect to physiotherapy, there were no agreed areas of concern. So basically there was just a lot of disagreement about what was an issue and what wasn't an issue. And we're not really sure why that was. The tool that we were using has been used before, but in nursing. not in physiotherapy or podiatry. And one of the sort of thinkings was that it's not clearly articulated what is expected to happen. So when we're assessing what we expect, there's a lack of agreement within the profession as to what to expect should happen. So therefore, when we're assessing it, we haven't really got a criteria for what we're really assessing. Does that make sense? So basically, there's more work to be done on that as a profession. And then in our project meeting, when we were sort of discussing it with the professional bodies, I think that there was agreement around that, because it's so emerging, that there is just a lack of sort of agreement around what this actually might involve. Within podiatry, there was more agreement over the levels of concern that were identified, and these concerns related both to assessment and diagnosis and communication. So it seemed to be there was a lack of agreement in general, but there was more disagreement in physiotherapy than podiatry. And in podiatry, the issues seem to relate around assessment and diagnosis and communication. Looking at the patient record audit, so we audited 153 patient records. And again, I think that it'll become as no shock to anyone in the room that the quality and completeness of patient records across lots of different systems can be very patchy and very difficult to audit. So the general quality and completeness of the records audited was quite mixed. We're only able to find 60% had any sort of GP letter post-consultation communicating the findings of the consultation back out. There was variability in the presentness or not of referral letters. Now, some of that we felt was probably due to the fact that a lot of the appointments were follow-up appointments. Some of the patients, particularly for podiatry, had been coming to see the same practitioner for a number of years. So how long would a GP referral letter be in the patient records for? There was a number of referrals in and out of services and to different healthcare providers. As I said, there was 18 prescriptions that were issued, 15 were analysed. Overall, the quality of these prescriptions was pretty good. There was some missing information on a few. The main issue was that people didn't actually write the dose frequency in words. They might have written it in numbers, but not in words. And two actually missed the quantity of medicines to be supplied. So some minor issues, but nothing really overly concerning. And then we undertook an economic analysis. And so some of the findings that we found from this were that the physiotherapy consultations were 6.8 minutes longer than the non-prescribers, and that because of this, these consultations are classed as more expensive. The independent prescribers also spent more time discussing the patients with colleagues outside of the consultation. So again, that has an impact on the costs that were calculated. But again, this all comes with a lot of caveats, because it's not a complete sort of full economic analysis. It's based just on literally the cold core time spent face to face. And that really is very dependent on the types of patients that are being seen. With respect to podiatry, there was also a difference between the prescribers and non-prescribers, and these consultations were classed as slightly more expensive as well. The prescribing patients received more medications than the non-prescribers, which is what you'd hope. The independent prescribers were requesting more tests, and of course these aspects are more costly, but again are more likely to reflect the type of patients that these practitioners were seeing, rather than any true difference as such. And these sort of economic aspects should really just be seen as indicative rather than 100% conclusive. We also asked people about the costs of the training, and the mean cost for undertaking a training, the conversion course was just under £700 and £1,600 for the combined course. So it's just really to sort of give an idea of the course costs. So to summarise, looking at what we set out to do, with respect to describing and classifying the services, what we found was there was a mixed and varied pattern of service configuration and work activities. And I think that should really come as no shock, because that's what we expect within the NHS. Service configuration is very different across the country. Looking at factors that facilitate or inhibit implementation of independent prescribing, we found that prescribing is acceptable to the majority of patients. Reassuringly, the key motivation is primarily for improving services for patients. Also, aspects around professional reputation, skills, legalising grey areas of practice and job satisfaction are important facilitators. Some concerns around the time for the course, availability of DMPs, and some resistance and lack of prescribing budgets were some of the barriers identified. And as I've mentioned a couple of times, this lack of strategic planning for implementation and embedding of prescribing within the services for the long haul. Looking at contributing to patient experience, there was a high level of patient satisfaction with some aspects of services and information. There was improved services for podiatry patients. Looking at the medicines management activities that contribute most to care outcomes. Although independent prescribing use is the most appropriate or convenient means to provide medicine, independent prescribing is used the most appropriate means, but whether that is prescribing PG exemptions or recommendations. So just because you are a prescriber, it doesn't mean to say that that's all you'll use. It's almost like you have a toolkit and you're still going to use whatever you think is best for your patient. Looking at the quality, safety and appropriateness of prescribing, as I said, we found a general high standard of prescription writing with a few causes for concern raised in the consultations. Independent prescribers provide more medicines management activity and medicines information than non-prescribers. More information could be provided to patients by podiatrists when administering medicines. Most clinical governance systems are reported to be in place, with the exception of access to prescribing data and means of auditing prescribing practice. Looking at the impact on costs, quality, effectiveness and organisation of care, there's some evidence to suggest that consultations could be more costly due to the fact that they're longer and they have increased medicines management activity, discussion with colleagues and referrals. However, it's very unclear if this is due to independent prescribing or service-related factors, so that does warrant further investigation. Looking at prescribing models and resource implications, we were unable to complete the micro-level cost analysis or to identify clear prescribing models due to the lack of data in some of the aspects that we collected. Looking at the educational programs, people overall reported high levels of satisfaction with their training. And then just some general conclusion. Physios and podiatrists working in specialist and advanced roles should be supported to adopt independent prescribing. Overall, there's evidence to suggest that we need a more strategic approach to independent prescribing workforce planning. We need more robust systems to capture data on medicines management activities. We need to consider where the benefits of prescribing can be maximised in service delivery. We need further economic evaluation and a greater understanding of service user and carer perspectives. And that's where we're at the moment. Thank you.